All right, so how does the musculoskeletal system differ between adults and the pediatric population? So to begin with, newborns have openings in their skulls called fontanelles, and they have an anterior fontanelle that typically doesn't close until around 9 months to 18 months. So if you are assessing a younger child, that's one of the things that you want to keep in mind. And also remember, younger children tend to fall head first because their head is so big, which increases their chance of a brain injury. So if you have a pediatric child or a pediatric patient that comes in and you know that they fell, you want to make sure that you check their mental status early and that you check it often and you look through their scalp for any signs of an injury. They also have a greater chance of blunt trauma to the chest and abdomen, so you want to palpate thoroughly and carefully. And of course, because their long bones are more flexible, they have a greater chance of partial fractures or green stick fractures of the long bones. And we're going to discuss a little bit the fractures in a few slides. But so my baby, I had to take him to the doctor, and this is exactly how they did his chest x-ray. And they just look so cute, don't they? But my child was screaming his head off the whole time. Okay, so let's focus on the musculoskeletal system of the elderly population now. And I am not promoting smoking, but you have to admit she's kind of a cool looking grandma, isn't she? Anyhow, all right, so we know that the older population has muscle loss. And while this may not sound like it's a big deal, muscle loss affects them in several ways. First of all, the decreased muscle strength and mass will also lead to abdominal protrusion. They're going to have increased rigidity in the neck, shoulders, back, hips, and knees. They're also going to suffer from decreased fine motor dexterity and decreased agility, so they may not be able to hold small things like they used to, which is a big deal for someone that, let's say maybe they used to make jewelry. Now they can't hold those small beads, so they don't have the fine motor skills to get, the string in through the bead holes. And they're going to have slowed reaction times and reflexes with slow conduction of nerve impulses along with the motor units. So they're going to have earlier fatigue with activities is basically what I'm trying to say. So how does the aging joints affect the assessment when you're assessing them? So when you assess them, you're going to see that the aging joints are going to be stiff. There's going to be decreased mobility, limited range of motion, possible crepitation on the movement, right, from those bones rubbing together. And you're going to have pain with motion or perhaps with weight bearing. You're also going to see that old people tend to shrink. They have a loss of height and shortening of the trunk, and this comes from the disc compression and also from their posture changes that they have as they age. They're also going to have bone loss, which again is going to lead to the shortening of the trunk like we discussed. But it's also going to cause back pain, stiffness, and it's going to put them at increased risk for osteopenia and osteoporosis. Okay, so sometimes I feel like we forget that part of nursing isn't just the physical assessment, but also the questions that you ask to get the history of that patient. Okay, so for musculoskeletal system, you want to make sure you ask several questions so you can get that subjective data. Questions like, do you take any drugs or herbal products to manage your musculoskeletal problem? A lot of patients think that herbal products or over-the-counter things don't need to be disclosed when asked, but it's important that they mention that as well, okay? Ask them, what their exercise pattern is. Do they use any orthopedic devices? Are they able to sleep all night fine without feeling like they have to constantly change positions at night because of the pain? Do they live alone? Do they have somebody that can help them? Do they have any sexual concerns related to this musculoskeletal problem? Lots and lots of questions that we can ask to make sure we thoroughly get that history for that patient, okay? And then, of course, physical-wise, we're going to observe the spinal curvature. Want to make sure there's no muscle atrophy or asymmetry. We're going to check the joints for any swelling, deformity, pain, asymmetry, and check to see if they have any tenderness upon palpation, right, of the spine or muscles. Of course, obviously, we want to do a full range of motion assessment as well as the strength, muscle strength on all four extremities. So we have seen an increase in soft tissue injuries, and these are related to the increase in people that are involved in exercise programs, but truly I blame boot camp and CrossFit because you're moving quite fast, and if you're not an expert, if it's not a workout that you've done several times, you might not be doing it correctly. So sprains and strains are the most common soft tissue injury that we see, and it's usually due to abnormal stretching or twisting forces, and it's often involved with the joints and the spinal musculature. So the sprain is injury to ligaments surrounding a joint, and again, usually from a twisting motion. So you're going to see it mostly on the ankle, wrist, and knee. And you have several degrees. You have first, which is a mild of damage, and then it can yield to a third classification, which would be severe. Now, strains are excessive stretching of a muscle, and it's also classified by the first degree being the mild and all the way to third degree, which is severe or actually tearing of the muscle. And you can have mild sprains and strains that are self-limiting and can resolve within 3 to 6 weeks. You always, get an x-ray done to make sure you rule out fractures. However, just know that severe sprains and strains may actually require surgical repair. And that's Aaron Rodgers that you see there, and he suffered from a calf strain. Initially, Rodgers suffered an injury, I think in week 16 of the 2014 season. Okay, so one way to prevent sprains and strains is to stretch. And I know that's so annoying because we all just want to go to the gym and just start working out right away. We don't want to spend those first 10 minutes stretching or warming up. But there is actually science to it as to why it prevents sprains and strains. So warm-up exercises increase the temperature of the muscle. Then it increases the speed of the cell metabolism and the speed of the nerve impulse transmission, basically resulting in better oxygenation of the muscle fibers. So also strengthening exercises that involve weight and resistance help improve the muscle strength and the bone density. And of course, it helps if you have good balance because it reduces the risk of falls. Ergonomics. So ergonomics is basically modifying repetitive actions. And it's especially important with repetitive strain injury. So you may have to get different type of equipment, like for example, a special chair for lumbar support, maybe if you have wrist problems, a special keyboard to provide some support for that wrist as you're typing. So it basically just means you want to modify your repetitive actions in a way that will not stress that injury further. And if you do have a sprain or a strain, we always recommend RICE, right? So you want to, R is for rest. You want to stop the activity immediately and you want to limit their movement. Some people may even need immobilization for it. And you're going to put ICE, which ICE helps because it causes vasoconstriction. It decreases the nerve impulses, which decreases the pain as well. And you want to apply it immediately. You're going to leave it on for 20 to 30 minutes. Then you take it off for about 10 to 15 minutes to help warm it up. For some reason, frozen peas, guys, work really well as an ice pack. Don't ask me why, but over years of experience, I feel like they work better than just ice. After the acute phase, the first 24 and 48 hours have passed, then you want to apply the heat for 20 to 30 minutes, then cool off for 10 to 15 minutes. So the C of RISE stands for compression. You basically want to limit the swelling. And E is for elevate. So you want to elevate the extremity above the level of the heart to help reduce the swelling. And of course you want to medicate with mild analgesic, maybe ibuprofen, Tylenol, something to help their pain out. Moving on to bone fractures. So there's different reasons for the bone fractures, but they typically fall under these three categories. You're going to have trauma, right? Car accident, twisting. It could be that you were jumping up and down, maybe in boot camp, and, twisted your ankle. But what I want you to be suspicious of is twisting injuries when it comes to children. Always suspect abuse. Okay, and make sure you are observant with the child and the parent, and if you suspect foul play, then go ahead and report it, follow up on it, whatever protocol your hospital, your unit has with it. And osteoporosis is on there because osteoporosis can be quite sneaky. A lot of patients don't really know they have osteoporosis sometimes until they have a bone fracture, and then that's when they're diagnosed with it. There's several complications that can occur from bone fractures, and we're going to further discuss these in the next few slides. But there are different types of fractures. What I want y'all to know is the four main ones, which is going to be open, which that picture that you see on the right upper side, that is an open fracture because it broke through the skin, right? And a closed fracture is, if you look at that little girl's arm down there, that would be a closed fracture. Clearly this bone is not the way it's supposed to be, but it didn't break the skin, so you're not actually seeing the bone. And you also have displaced fractures where the bone breaks into two or more pieces and it moves so that the two ends are not lined up straight. In a non-displaced fracture, the bone cracks and it can crack, part of it or all the way through, but it does not move and it actually maintains its proper alignment. So I'm hoping that this mnemonic broken will help y'all remember a little bit easier some of the signs and symptoms that you're going to see from a patient who has fractures. And yes, I know that that's not how you spell crackling, but I needed to fill in the K, and I also needed to make sure that y'all knew that you could hear a crackling sound. And that crackling sound is actually called crepitus, and where it comes from is basically from the two bones that are rubbing together. Um, and it sounds a little bit like Rice Krispies. If you get Rice Krispie cereal and you pour milk over it, you know how it starts popping? That's about how the sound that you're going to hear with crepitus. So of course you're going to see edema, swelling, pain, tenderness, muscle spasm. Obviously you're going to see deformity. And if it's an open fracture where you can actually see the bone, you want to cover with a sterile dressing to prevent further contamination. The main thing with this, guys, is the emergency management of immobilizing the bone in the position that it's found. And the reason why is because if it's a closed fracture and they're still moving it, it can actually convert into an open fracture. And that's going to cause even further damage to the surrounding structures. So we want to immobilize it. We want them to not move it because it can cause further muscle and tissue damage, and they can displace the bone even further. Okay, so in the mnemonic, broken, N stood for neurovascular impairment. But the only way you're going to know if there is a neurovascular impairment is by doing your assessment as a nurse. So it's very important when you're assessing the patient to check for all of these 6 things that are listed here. And you're not going to check just, when they first arrive, but you want to make sure you assess the status of that body part before and after splinting or casting the extremity or traction being in place. Because if there is a change, whatever intervention we did could be making things worse. Perhaps we cut off the circulation to that, or perhaps compartment syndrome is developing. So it's very important that you assess, and you assess correctly, and you assess constantly. So the treatment goal for fractures is we want to not only realign the bone fragments, but we want to realign them and heal them in a way that there is complete restoration of function to that body part. Sometimes this is doable, sometimes depending on the severity of the fracture, there is going to be some deficit. But there's different ways to help this goal, and it can be either through manipulation, traction. They also do something called closed and open reduction, and you're going to see what a closed reduction looks like in this video. But basically, a closed reduction is a non-surgical realignment of the bone through manual manipulation. And it's usually done under local or general anesthesia, and then they typically put it in a cast or a splint, sometimes a brace, something that's going to apply and maintain the alignment and immobilize it at the same time until the healing occurs. Okay, so we looked at closed reduction. Now we're going to look at open reduction. The goal is still going to be the same. We want to restore the alignment, but this time we're going to restore it through a surgical incision. And it's going to include internal fixation of the fracture with wires, screws, pins, plates, rods, or sometimes even nails. The main problem with this type of surgery is the risk for infection, especially if your patient is diabetic. For 2 reasons. First of all, you've broken the main protective barrier, right, which is the skin. And second of all, now you've added hardware to the body that is typically not there. But the positive thing is it promotes early ambulation, so it helps decrease all the complications that you would get from being immobile for too long. Some general things to keep in mind with bone fractures is you want to make sure to give them the best chance at restoration of function. You need to consider their nutrition requirements that they need. So want to make sure they're getting adequate protein, their vitamins B, C, and D, that calcium, phosphorus, and magnesium levels are all at a good standpoint, because these are things that are going to promote healing of that bone. And you also want to stop and assess how their treatment is affecting their mobility. Are these patients, not able to walk to the bathroom anymore? Because if they're not, then you're going to have to promote adequate fluid and fiber intake so that they can continue the bowel and bladder function as if normal. And these are the patients that, the doctors are going to prescribe stool softeners for to help promote that bowel function so that they don't become constipated and they don't develop an ileus down the road. Let's talk about cast. So there's different materials that they can use for a cast. You have something called plaster of Paris, and the good thing about the plaster of Paris is that it can be easily molded and it's typically less expensive. However, it has a lot of disadvantages, and the main one is that it takes several days to harden. So it's not something that they can slap on, you walk away, and it's done. It's something that, if you break a leg and they have to put the plaster of Paris on it, then you won't be able to bear weight on it for 24 to 72 hours after the application, because you want to make sure it's 100% dry. It also doesn't breathe very well, the air doesn't circulate, and it's quite heavy. And of course, you cannot get it wet because the plaster is going to disintegrate. You have something else called synthetic cast. And this one is just so much lighter. It's also stronger and waterproof. But just know that the inside, the padding, is typically not waterproof. Another advantage is that it's more breathable than plaster, and also you don't have to remove it to take x-rays, which is a great advantage. And you're going to have different types of cast. A short arm cast is typically used for the treatment of stable wrist or metacarpal fractures. And then you have something called the long arm cast, and that's going to be used for a stable forearm or elbow fractures, and also for unstable wrist fractures. So you're also going to have something called, long leg, which you're going to use for unstable ankle fractures, tibia fractures, and knee injuries, and the short leg, which you're going to use for stable ankle fractures and foot injuries. We know that casts are placed when a patient has bone fractures. So the main thing is to monitor the neurovascular status. This is when we monitor the 6 Ps. Remember, the pain, paresthesia, paralysis, pressure, all those things. And what I want you to remember is that pain is going to be the early sign, and pulselessness is going to be a very late sign. You also need to monitor for infection. We want to make sure they don't have hot spots or odors coming from the cast. We want to make sure we check the skin integrity and that there's no breakdown from the outer part of the cast. So we can do something called pedal cast with soft tape. And basically what it is, it's this very type of soft tape that you just put around the edges so that there's not that constant rubbing on it. And you have to, of course, teach the patient that the cast needs to remain dry and that we want to elevate the cast above the heart level with pillows to help decrease the swelling. For the neurovascular assessment, remember, we want to check the peripheral vascular rate, which is distal to the injury. Don't forget, to also assess for the cap refill. And you're going to check the neurologic systems as well, so sensation, motor function, and pain. You want to move the joints above and below the area of the immobilization to prevent stiffness and reduced function. So you want to exercise the joints above and below, and you want to teach them how to do that so that they don't lose that function as well. Let's talk about traction. So traction is the application of a pulling force to an injured or diseased body part or extremity. And it can be used for several reasons. We can use it to help prevent muscle spasms, which in turn would help reduce the pain. It can be used to immobilize the joint or a body part to help reduce fracture or dislocation. And it may aid in treating pathological joint conditions as well. And there's different type of tractions. Right now, let's discuss the skin traction. And the skin traction is generally used as a short-term method. It's 48 to 72 hours, typically very low weight, 5 to 10 pounds, and it's due to maintain the alignment in anticipation of surgery or skeletal traction. It's done by attaching directly to the patient's skin to immobilize the body part continuously. And the direct application of a pulling force to the patient's skin and soft tissues may be accomplished by using adhesive or non-adhesive traction tape, or other traction devices such as a cast, a boot, a belt, or a halter. So as a nurse, you have to keep in mind that when you're putting traction, you're also putting a lot of pressure in a very specific area of the body. And you are, in this case with skin traction, you have a piece of cloth or tape or a belt or a halter that is continuously putting pressure on the skin. So you want to make sure you assess for pressure necrosis, that you make sure you check, impaired blood flow. You want to check your pulses, your neurovascular status that we talked about every 4 hours. So bucked traction is a type of skin traction, and it's sometimes used for the patient with a hip, knee, or femur fracture. And you elevate and support the leg while the boot is applied, and you make sure to position the heel in the heel of the boot. The Velcro straps are going to secure the boot around the leg. So if you look at your Lewis book, page 1453, figure 62-9, that's going to show you what I'm talking about with the boot strapping around the leg. And then the rope is attached to weight and is secured to the bottom plate of the boot and threaded through the pulley, and the weight hangs off the end of the bed. You have to be careful not to bump the bed or the weight. One, because it's quite painful for the patient, but two, it's also quite painful for you. Trust me, I've done it. And you want to release and resume weight gently. Please do not do this in a rush, okay? If you are going to go into a patient's room where you know you have to release the weights to be able to turn and you're going to have to pull them and all of that, then make sure you mark enough time off of your schedule so that you can do it gently, because it's a process that is very lengthy. So you want to one by one remove the weights. You're not going to pull 2 or 3 off at a time. It has to be done one at a time and quite gently. The same when you're placing them back on it as well. So you want to assess the skin under the boot every 2 to 4 hours, especially the heel because of all the pressure, remember? So you can see how the traction is pulling on the leg. Well, if the weight was on the floor, then the traction would not be working, right? It seems like common sense, but you'll be surprised how many times I've walked into a patient's room and the weight is on the floor and then it's not doing anything, right? So how can you assess for the pressure area on the patient's back and sacral areas, or how can you provide skincare there? And basically, you're going to have the patient lift the booty off the bed by bending and pushing with the unaffected hip leg. This is a great stopping point for you to just take a break, take a deep breath, and analyze what you have read on the last few slides and what you've heard. See if you really comprehend everything. If you can't, then go ahead and look at it again before you proceed into the PowerPoint. And then if you still don't understand, write down your questions so that we may discuss them, and hopefully I can clear things up for you during our lecture time. Skeletal traction is the least, at least my least favorite type of patient to take care of, and I have a feeling it's probably going to be y'all's least favorite type of patient to take care of, because they are just very complicated and time consuming to work with. And we use skeletal traction to align injured bones and joints. You can use them in contractures and congenital hip dysplasia as well. The proper amount that you use is super important, because you can actually do more harm than good. If you use too much weight, you can cause a delayed union or non-union of the bone. And Lewis' textbook will tell you that you use 5 to 45 pounds, but I have seen up to 55 pounds of traction being used at the hospital. So it just differs on the size of the patient and which bone you are also working with. So with the skeletal traction, you want to assess your neurovascular status just like with the previous traction. So we're going to check for the 6Ps, and we're going to do it every 2 to 4 hours. However, one thing that's different with this is that you're going to have to provide very good pin care. And what I mean is, with the skeletal traction, you have a pin that goes into the bone and then comes out of the skin, and it can be exposed anything from 1 to 3 inches outside of the skin, which complicates things for several reasons. First of all, it's very easy to get caught in the sheaths, to get caught in the patient's gown as well, and if the patients insist on wearing underwear, trying to put on underwear and take it off is just a pain to put on and take off as well, and it's very painful for them. Another problem is if you have a patient who is intubated and also incontinent, you are now exposing those pins to their bodily fluids, whether it be diarrhea or whether it be urine. In the ICU, you do have things, such as condom catheters for those patients that don't have Foley's. However, sometimes those condom catheters fall off, they're not placed appropriately, or, just things like that happen. And then that urine goes all over those pins, and those pins are attached to the bone. So can you see what a high risk of infection we have here? Which is very important for you to be super diligent in the way that you care for those pins. You're probably going to have to do pin care at least twice a shift. Of course, if they're soiled for any reason, you're going to have to do it more often than that. And it's not something that you just want to put in the back burner. It's something you have to be diligent about. Another problem with skeletal traction is that it really does limit their mobility, and it provides prolonged immobility, which is a huge risk for skin breakdown. Also, prolonged immobility can lead to orthostatic hypertension and decreased lung capacity. The decreased lung capacity will lead to some other complications down the road if, if they stay in bed too long. And you want to remember this, the orthostatic hypotension and decreased lung capacity is something that happens to any and all patients who are, immobilized for a long period of time. These are some of the types of traction, the most common ones that you're going to see, whether in the pediatric setting or in the adult setting. But the Russell's traction is used in patients that are 5 and older, and it can be used on one or both legs. And it's typically only 2 to 5 pounds of weight per leg. Again, remember, we do not want those weights touching the ground. Otherwise, they're not doing anything. And it's used as a pre-op traction for hip fractures as well. It helps pull the contracted muscles, and it can be used as a treatment for leg calf Perthes disease. I hope I said that correctly. We also have the ballast suspension traction, and it's used in patients 3 and older. It's typically on the upper tibia and thigh. It's with 20 to 35 pounds of weight, and it helps the realignment of fractures of the femur. Sometimes when you realign those fractures of the femur, you're also going to help them with the relief of muscle spasm pain that's associated with it. The cervical head halter, it's really weird. I've only seen it once. And it's used in adults under the chin and around the face and the back of the head. Not too much weight, of course. It's going to be anywhere 5 to 15 pounds. The one that I saw was only 5 pounds. And it helps with the relief of muscle spasms caused by the degenerative or arthritic conditions of the cervical vertebrae or by a muscle strain. And of course, box we already talked about, and pelvic traction. So what are you as a nurse going to do for your patient who's about to go into surgery to fix a fracture? So preoperative, you're going to, of course, educate them as to what's going to happen in the OR, and then also what they can expect when they come out straight of the operating room, and give them a realistic pain expectation level as well. Some patients I find truly believe that they come out of the OR and will not experience any pain whatsoever, and that is not a realistic expectation, unfortunately, for most of them. You also want to, of course, do the proper skin preparation, things that we've talked about in the previous lectures. And you're going to do your neurovascular assessment before they go into operating room, and it's the first thing you're going to do when they come out of the operating room, because you want to know if there was a change in that baseline, and if the change was a positive one or a negative one. Second of all, you're going to evaluate the cast or the immobilizer or the dressing for any signs of bleeding or drainage. And you want to mark it as soon as you evaluate it so that you can see if there is any increase on it. You also want to take a special note of the drainage, because you want to know, was it just kind of yellowish and then it turned into sanguinous or serosanguinous? Was there a change in that? Because that's something that you have to document and you have to notify the doctor. Also, sometimes they have a wound drainage system in place, and make sure you evaluate it for the patency and the amount of drainage that is measured. So measure it, mark it when the patient gets to you, and mark it at the end of your shift, and make sure you document it. You can expect a small amount. However, I always like to ask the doctors, how much drainage would you be concerned if they put out in the next 4 hours or so? And that way I just have something to measure by. So the reason why they come out with the wound drainage system is because it helps kind of decrease the pressure of the fluid in the wound. And too much fluid in the wound will not only cause pain, but it will also impair the circulation and impair the wound healing as well. In most cases, the patient may go home in a cast or in a type of immobilizer, so you want to make sure you teach them the key elements of proper cast care or the care of an extremity and when to contact the physician if essential. The patient or family must be educated. I always educate both. Even if the patient is oriented times 4, I always find a family member to educate as well. And you want to educate him, you have to educate him on how to do a correct neurovascular assessment. There are so many complications to fractures that can occur. Some of them are non-life threatening, like becoming constipated, right? Unless it develops into an ileus. And the other one, believe it or not, can actually be renal stones. And that's because they develop from bone demineralization due to the reduced mobility. So, those are a couple complications that can happen, but they're not life-threatening. However, there are life-threatening complications such as infection, which is a more common one, and that happens mostly in open fractures and soft tissue injury because the damaged tissue is a good medium for bacterial growth. Osteomyelitis is the infection in the bone due to direct open skin or indirect invasion. And this comes from, remember those pin cares, the pin care that we were talking about whenever you have skeletal tractions and things like that. So the problem with osteomyelitis is that it can become a chronic infection. It's just something that has to be treated constantly for the rest of that individual's life. The other complication is compartment syndrome, and compartment syndrome is basically excessive pressure within the myofascial compartment, and it results into neurovascular compromise. The condition is not only associated with fractures, it can happen with other things such as burns, IV infiltration, and also from a cast that is too tight. So initially the venous blood flow is impacted, but it can also impact the arterial circulation. And the problem with this is that it's a very time-sensitive issue. Time is not the patient's friend in an unrecognized compartment syndrome. When you have edema that restricts the venous flow, this can result in loss of function and severely impaired extremity because eventually the arterial flow is also going to be compromised, so the nerves are going to be impaired. The most common site typically for compartment syndrome is the lower extremities associated with tibial fractures. After that, it's usually the forearm. It occurs about 4 to 6 hours after the injury or application of the cast or a dressing, like I said, if it's too tight. If it occurs, surgical decompression called the fasciotomy may be necessary. And the only way you're going to see this is by assessing your 6 P's, right? Your paresthesia, your pain, your pressure, pallor, paralysis, your pulses, are they diminished or are the pulse completely gone? The patient is also going to complain of unrelieved pain, and this is going to be one of the very first symptoms that you're going to see. You're going to be giving this patient pain medicine after pain medicine, and the pain is not going to go away or decrease for this patient. And just know that the sensory or motor deficits are very late signs, and they should not be there because if you're doing, your assessments the way that you should be, you should have picked up on it fairly soon. Pulses are not lost until permanent damage has occurred. That is the point of no return, unfortunately. And additional problems that are related to compartment syndrome can be rhabdomyolysis, hyperkalemia, myoglobinuria, infection, and gangrene. Again, they may require surgical intervention called a fasciotomy. Another complication is thrombosis, right? So venous thrombosis. Veins in the lower extremity and pelvis are highly susceptible to a thrombus formation, which is a clot. If the cast is incorrectly applied, traction or immobility are not done correctly, it can also cause a DVT. And you want to have prophylactic treatment. So early ambulation, and you're going to find these patients on anticoagulation therapy as well. Typically a low molecular with heparin or Lovenox, and things that are not going to require a lot of monitoring for the bleeding time. Fat embolism is basically where systemic fat globules from the fractures are distributed into the tissues and organs after a traumatic skeletal injury. The problem with this is that it most commonly occurs with fractures of the lung bones, and fat embolisms can travel anywhere and they can travel to the lungs as well. It's going to manifest, the clinical manifestation is usually going to occur 24 to 48 hours after the injury, but it could occur earlier or even later than this. And early recognition and response is important. The symptoms are going to reflect where the emboli location is. So for example, if it's in the lungs, your signs and symptoms are going to be acute respiratory distress, chest pain, tachypnea, cyanosis, dyspnea, apprehension. I've had patients who just tell me they feel anxious and they can't quite tell why they feel anxious. And then an hour later, it turns into respiratory distress, and the whole time it was a PE. So you want to investigate memory loss, restlessness, confusion, things like that. Any elevated temperature and headaches, because the central nervous system involvement, you want to make sure it's not mistaken for alcohol withdrawal or acute head injury. And the way to prevent this is, again, early immobilization of the long bone injury or minimal manipulation of a fracture before immobilization. Treatment is going to be symptom directed and generally fluid resuscitation for hypovolemic shocks. You're also going to correct acidosis and give blood transfusions as needed. So I saw this and I laughed so hard because I had something similar like this happen to me. I had a patient with a very obvious broken leg, and the technician, x-ray technician, came, took a picture, and I jokingly asked him, "So, is it broken?" And he looked at me and said, "I'm not allowed to say, you'll have to wait for the results to come in." If any of y'all are planning on working with the elderly when you graduate, then definitely pay attention to this because you are bound to see it in the first 2 years of your nursing career. And if you're not planning on working with the elderly, well then still pay attention because you're going to see it on your test. But let's talk about hip fractures. So hip fractures are just a huge catastrophic event for the elderly person. Even if it's not fatal, it causes a huge negative impact on their lifestyle and their quality of life as well. And it's unfortunately very common in the older adults. So we have about 320,000 patients a year that go into the hospital because of a hip fracture. And out of those, 37% of them die within the first year. And the reason why is because there's so many complications that come from a hip fracture. But just know, there's two different types of hip fractures that you're going to see. You're going to see the intracapsular fractures and the extracapsular fractures. And when they have a hip fracture, it's going to be pretty obvious. You're going to see some of the clinical manifestations listed there, the shortening of the affected leg and absolutely severe pain. Immediate surgery is going to be your standard of care. There's no other way around it. They may mobilize the extremity by using the Bucks traction that we had seen earlier in the previous slides. And usually it's used about 24 to 48 hours before they do the surgery. It helps some with the pain, more specifically because it helps with their muscle spasm. But the good thing is the surgical treatment will allow them for early mobilization and it decreases the risk for major complications. The type of surgery is going to depend on the location, severity of the fraction, and the person's age as well. We can either repair with an internal fixation device, which is called a hip compression screw, and there's a picture right there on the right-hand side, or we can replace the femoral head with a prosthesis, a partial hip replacement is what it's called, and the medical terminology is hemiarthroplasty. And this is often going to be done with the femoral neck when the femoral neck is fractured. And then last but not least, we can do a total hip replacement, and that's going to involve the femur and the acetabellum replacement. However, it is quite an extensive recovery, so we have to take into account the patient's age. So nursing management for hip fractures. With these patients, you absolutely want to make sure you do the TCDB every 2 hours. And for those of y'all that don't know, that stands for turn, cough, and deep breathe. And you're going to encourage the deep breathing by using the incentive spirometer that should be at their bedside. You also, of course, want to check your vital signs. You're going to be very cautious with the intake and output, right? Because you want to make sure they're not retaining urine. That's then is going to cause a UTI that could lead to something worse. And you also want to make sure they are on VTE prophylaxis stuff, such as Lovenox. So elderly clients with hip fractures are more prone to complications. And the problem is VTE is the most common. So, you want to encourage the fluids. And you want to adhere to the VT prophylaxis protocol by putting on TEDs, making sure their SCDs are on, and Lovenox therapy is typically in place as long as it's not contraindicated. You also want to teach them how to do the foot flexion exercises to prevent thromboembolic events, and you should teach the family members as well for whenever you're not able to do it. They can be there and assist with that. There's always a potential for neurovascular changes, so make sure you observe the extremity, the 6 P's: color, temperature, cap refill, the pulses, edema, sensation, motor function, and pain. Guys, you should be able to recite these by memory by the time you go in and take the exam. You want to do your part to prevent the dislocation of the hip as well. So make sure you use the abduction pillow whenever you're turning or whenever you're, using the posterior approach. You want to maintain the alignment, and you want to make sure you provide support when turning the client. You also are going to see that they're going to have an overbed trapeze, and that's going to help them and help you. Because they can lift themselves up with their arms to help turn and things like that. They should be getting turned and repositioned frequently. The patients are going to fight you in this matter because it is very painful for them, but you want to prevent pressure ulcers. And when you're turning the patient, use pillows in between the legs to maintain the abduction position. So you're also going to be assisted by physical therapy with transfers, and they're going to help institute the early ambulation, of course, once the physician clears the patient to start doing it. Frequently, you're going to see that elderly clients are discharged to extended rehab care facilities until they can regain independence with their ADLs. So the nurse should assess for needed home modifications such as raised toilet seats and grab bars in bathtub or bench in the shower. You should never discharge an elderly patient and take their word for what is at home. You should always interview a family member as well and make sure that it does match what the patient is telling you. A lot of the elderly patients, you're going to notice, don't like to be helped. They are not keen to the idea that they can't do things to themselves, and a lot of them want to be in their own homes resting. So they will tell you what they have to tell you for you to just send them on home. So make sure when you are asking and interviewing as to what they have at home that you also ask a family member and make sure everything lines up. With hip arthroplasty patients, you want to educate them in selecting their chairs carefully to be sure that their hips are not going to end up any lower than their knees. There are several goals for joint surgical procedures. They're listed there, but overall, the main goal is to help maintain the function. There are different types of joint surgeries. A synovectomy is the removal of the synovial membrane, and it's performed to remove the inflamed tissue that's causing the intense pain or perhaps limiting the range of motion, typically related to rheumatoid arthritis. The removal of the thickened synovium does not actually cure the disease. It's simply to relieve the symptoms, and it's only temporarily. It's commonly done in the elbow, wrist, fingers, not really in the knee because typically they just get a joint replacement done there. An osteotomy is the removing of a wedge or a slice of bone to restore the alignment and to shift the weight bearing, relieving the pain. It's kind of hard to envision what an osteotomy is. That's why I included a video for you to kind of get a better idea of what it looks like. You'll see something called the cervical osteotomy very rarely, but it is used to correct kyphotic deformity in patients with ankylosing spondylitis. And these patients will have to wear like a halo vest and body jackets for about 3 to 4 months until the fusion is complete. You're going to take care of osteotomy patients the same way you would take care of an ORIF patient. Debridement is a removal of degenerative debris such as pieces of bone or cartilage or osteophytes from a joint. It's usually done as an outpatient, and it's typically done on the knee or shoulder. You're going to have a compression dressing applied post-op, and weight bearing is allowed post-debridement. You're going to want to teach the patient to monitor for infection, so you'll teach them all the signs and symptoms of infection, how to manage pain, and restricting excessive activity for 24 to 48 hours after the procedure is done. Arthroplasty is the reconstruction or replacement of a joint, and it can be done for three reasons actually. 1, to relieve pain. 2, to improve or maintain range of motion, and 3, to correct deformity. It's most commonly done on patients with OA and RA. sometimes avascular necrosis, congenital deformities, or dislocations. However, you're going to see that the hip and knee are the most common, but you will see that Lewis is going to mention a few others as well. There are two main indicators that qualify the patient for a total knee replacement, or a TKA. And basically, unremitting pain and instability resulting from the severe deterioration of the joint are the main indicators. Partial arthroplasty can be done if osteoarthritis is limited to one area, basically if it's compartmental. For post-op, as a nurse, your main goal is going to be pain management. And not just because you want the patient to be comfortable, but also because if the pain is not managed correctly, it's going to significantly reduce the patient's ability to participate in therapy. For a knee joint replacement, physical therapy is going to be gold. You're going to begin with isometric quadriceps settings, then straight leg raises, and gentle range of motion exercises to increase the muscle strength and help obtain a 90-degree knee flexion. A CPM machine, which is that machine that you're going to see on the upper right hand corner, helps with active flexion or even passive flexion exercises. With a knee replacement, ambulation begins fairly early, guys. They typically do a full weight bearing prior to discharge, and they're typically discharged the day of surgery, the day after latest. I forgot to tell you guys that before you can take your exam, you have to be able to perform this dance. Osteomyelitis is a severe infection of the bone, bone marrow, and surrounding soft tissue. Although Staphylococcus aureus is the most common cause of infection, a variety of pathogens can cause osteomyelitis, and you can get osteomyelitis pretty much anywhere in your body. It's interesting because osteomyelitis in the spine was very rare to see, but physicians are seeing it more cases nowadays, and it's because of injecting bacteria along with heroin from drug users. So the thing is, heroin users risk showering their bloodstream with bacteria that live on their skin and needles. And the bacteria can travel to the spine, plant there, and fester into a painful infection. So I have actually seen young patients with osteomyelitis, and it is because of drug use. Acute osteomyelitis is going to be considered the initial infection or an infection that lasts less than a month. Chronic osteomyelitis will last longer than a month, and of course, there's going to be failure to respond to antibiotics. It can also include the process of exacerbations and remissions as well. Biopsy is a definite way to identify the organism that is causing the osteomyelitis. Interestingly enough, with osteomyelitis, the signs of infections do not appear on an x-ray until 10 days or even later after the initial symptoms are reported. This is why MRI is the most sensitive test for this type of condition, and after that CT scan, with x-rays being the last resort. Aggressive, prolonged IV antibiotic therapy is going to be the treatment of choice for acute osteomyelitis if bone ischemia has not yet occurred. Ideally, cultures and bone biopsy should be done before, that way we know what type of antibiotics to use. If there's any related soft tissue abscess or ulceration, it's most likely going to need surgical debridement or drainage as well. IV antibiotic therapy will start in the hospital, but it typically continues at home, guys, because it's going to be a long process. It's 4 to 6 weeks. For chronic osteomyelitis, you're going to have the surgical removal of the poorly perfused tissue and dead bone, as well as extended use of antibiotics. Typically, the therapy is going to be at least 8 weeks, if not longer. The acrylic bead chains, they're so interesting to me, and that's a picture of them right there. And it's basically just beads that are stuffed with antibiotics inside, and they just throw them into the wound to kind of help combat the infection. There's also something called a hyperbaric oxygen chamber. These are amazing. They're used a lot in the burn units, and not all hospitals have them. They're very expensive to have, but they are very effective at stimulating new blood growth and healing of the infected tissue. You want to teach the patient the possible adverse and toxic reactions associated with prolonged high-dose antibiotic therapy. These reactions can include anything from hearing deficit to neurotoxicity, headaches, behavioral problems, and so on. There's different reactions for different types of antibiotics. So, for example, cephalosporins, you're going to see hives, severe watery diarrhea, blood in stools, and mouth sores as well. With fluoroquinolones, which I can't pronounce, you're going to see something called tendinitis or tendon rupture. So, for all of your antibiotics, you want to monitor the peak and trough blood levels and also warn them that lengthy antibiotic therapy can cause overgrowth of Candida albicans or C. diff, which is a severe form of diarrhea. You want to teach the patient to also report any changes in the oral cavity, that could be signs of Candida. Let's talk about osteoporosis. So osteoporosis is a chronic progressive metabolic bone disease, and it's marked by low bone mass and deterioration of bone tissue, leading to increased bone fragility. Osteoporosis is unfortunately also known as the silent thief because it slowly robs the skeleton of its banked resources. Bones eventually become so fragile that they cannot withstand normal mechanical stress. And osteoporosis typically occurs most often in bones of the spine, hips, and wrist. Early manifestations are back pain and spontaneous fractures. So you'll have a patient who had no idea he had osteoporosis, typically because they don't go to the doctor, maybe they don't have insurance or they don't have anyone to take them, whatever the reason it may be. They try and get up, and just the simple action of attempting to get out of a chair breaks their bone. They go to the hospital, and that's when they realize that they have osteoporosis. Osteoporosis is more common in females for several reasons, but other risk factors include advanced age, low body weight, cigarette smokers, estrogen deficiency. Big one is long-term use of corticosteroids causes porous bones. So what kind of patients are on steroids a lot or constantly? Asthmatic patients, right? So if you have a patient with asthma who is on corticosteroids, make sure you give them teaching on ways to avoid osteoporosis. So this is why it's called the porous bone disease. If you look at the top bone, that's the healthy one, versus the bottom one, you see a whole bunch of little holes everywhere. So it's not a stable bone. And if you look at the skeleton picture, that is showing you how the person decreases in height. And the reason why is because a person who has a vertebral fracture due to osteoporosis has an increased risk for having a second vertebral fracture within 1 year. And over time, the vertebral fractures and the wedging cause gradual loss of height and a humped thoracic spine called kyphosis. An osteoporosis diagnosis cannot be achieved through an x-ray because it's not detected by a standard x-ray until about 25 to 40% of the bone has already been lost. So instead, we measure the bone mineral density, and there's two exams that we use to measure this. First of all, let's talk about bone mineral density. It's expressed as grams of mineral per unit per volume, and it's determined by the peak bone mass and the amount of bone loss. We use two tests to help us get these results. One of them is called QUS, and what it does is that it uses sound waves to measure the bone density in the heel, kneecap, or shin. Then we have DEXA. DEXA measures the bone density in the spine, hips, and forearm. This, by the way, is considered the gold standard by the World Health Organization, and the reason why is because these sites represent the most common sites of fragility fractures from osteoporosis. The BMD test results are then compared to the ideal density of a healthy 30-year-old adult, and they're reported as T-scores. Know that the more negative the number, the worse the bone loss. Buckle down, guys. There's a lot of information that I'm going to tell you on this slide, so make sure you have a piece of paper and a pen ready and that you're paying attention. Before I go through the drug therapy, I want to explain to you how bone remodeling typically works, and I wanted you to understand the difference between osteoclast and osteoblast. I think if you get this down, it's going to make sense how these medications work. So bone remodeling is a coupled process by which osteoclast remove the existing or damaged bone matrix, and then osteoblast refill the resorption cavities with new bone formations. This coupled process of a continuous renewal helps to maintain the mechanical strength of the skeleton. So with that being said, osteoclasts are large cells that dissolve the bone, and osteoblast help refill the resorption cavities with new bone formation, right? Okay, let's move on now to our drug therapy. So biphosphonates, they inhibit the osteoclast activity. So what they inhibit is the large cells that dissolve the bone. And an example of that is Fosamax. That's the one that you're going to see the most common. Side effects include anorexia, weight loss, and gastritis. And there's three things you want to teach your patient with this medication is you want to teach them to take it with a full glass of water. You want to teach them to take it 30 minutes before any other medications and to tell them to remain upright for 30 minutes after taking it. There are other types of biphosphonates that can be given by infusion and given less frequently, but Fosamax is going to be your most common. As a nurse, you want to make sure that renal function tests and serum calcium tests are done prior to them being started on this medication. Calcitonin. So normally calcitonin is secreted by the thyroid gland and it inhibits the bone resorption by interacting with osteoclast. We can also give it, as you can tell, and it's available as stated up on the slide. However, if you give it IM or sub-Q at night, it helps decrease the side effects of nausea and the facial flushing. And while you may not have nausea with the nasal spray, it has its own set of side effects such as nasal dryness and irritation and continuous rhinitis. One thing you want to teach your patient is to take calcium supplement with calcitonin. We move on to SERMs. SERMs mimic the effect of estrogen on the bone by reducing the bone resorption without stimulating tissues of uterus or breast. It's actually very effective in postmenopausal women at increasing the bone mineral density. Some of the side effects are leg cramps, hot flushes, but the big one is blood clots. So you want to teach the patient not to sit for a prolonged period of time. Teriparatide is a recombinant form of human parathyroid hormone that increases action of osteoblasts. Remember, osteoblasts refill the resorption cavities with new bone. It can be used in both men and women, including those who have been taking corticosteroids for a long time. Remember, asthmatic patients are patients who have taken corticosteroids for a long time typically, which places them at risk for osteoporosis. It was the first drug approved to help stimulate a new bone growth. You're going to teach the patient how to self-inject because it is a self-injected medication in a preloaded pen. And they're going to give it once daily, and the pen comes with enough medication for 28 days. You want to teach them to keep it refrigerated as well. The side effects are going to be nausea, vomiting, weakness, or dizziness. I'm sure you're feeling extremely overwhelmed from all the information you just got in this lecture. It's a lot to take in, I understand, but it's going to be okay. Just go over it again, read your textbook, and as you're studying, write down the questions that you have. And that way you can either answer them as you're looking through your book or the PowerPoint. And if you still cannot figure them out, then that's what I'm here for. So we will discuss them during our lecture time.